So UNOS is the United Network for Organ Sharing. It's a nonprofit charitable organization that works under a federal contract. All right, it's a strange bird. In 1984, Al Gore, who really did invent the internet, that was a joke, was a sponsor for the National Organ Transplant Act. The law outlawed the buying and selling of human organs, so you couldn't buy a kidney, you couldn't buy a liver. They, however, did not extend it to things like sperm. They created an organ procurement transplantation network, so one network that would cover the whole country. And they established registry so that we would actually have data that we have presented to you in the first lecture. If you look over time, you can see that we've had an interesting split recently, that we've had deceased donors going up and live donors going down. Live donors mainly, but not exclusively, for kidneys. Can have some live donors, much more restricted in the case of livers. As we've mentioned over and over again, this is a situation of absolute scarcity. You have the number of people on the waiting list going up and up and up. You have the number of donors slightly going up, the number of transplants slightly going up, but the gap actually increasing over time. Roughly 3 times as many people are waiting for organs as we have available. And we gave you the data last time about livers, that even if we dragooned every available liver out there, we would not solve or address the full demand for livers. So this is a classic case of absolute scarcity. Unlike the production of insulin or the production of penicillin, very hard to solve this problem any which way. You can see the distribution of donors, deceased donors, by region, although I think this, if you look at that, you can see the region. I want to ask you a question. You're now a newly minted transplant surgeon. Where would you locate your transplant center in the country were you to launch it? Would you locate it right here in sunny Philadelphia, Pittsburgh, Chicago, Seattle, Denver, Los Angeles, or at the Harvard hospitals at Boston? Denver, Los Angeles, Chicago, Philadelphia. Maybe some of you like it here. No one in Boston, few people in Pittsburgh, no one in Seattle. So one of the things I want to draw your attention to in this slide is this is overall donation rates per 1,000 deaths, okay? And the darker you are, the more you get. Per 100 deaths, sorry, okay? So you might want to see, you got this nice little band here, you got a band here, you got, this isn't at the top, but there's a big band here, okay? Yeah, on the other hand, locating it in, is that Alabama, Mississippi? Locating it here, where there's a lot of white, might not be such a hotsy-totsy idea. If you're a transplant surgeon, what you really want to do, right, is look where there are lunatic drivers going straight for a long time at a very high speed, right? So, you know, I looked at this map and you say, well, look, that's Iowa, right? Nebraska, Kansas, Missouri, Southern Illinois. What's there? Flat cornfields, right, exactly. Flat cornfields, where you can easily get lulled into driving very fast, right? And what's there? I don't know, maybe there's, you know, gunshot wounds or something. But, you know, the famous liver surgeon who just got a Lasker Award, Tom Starzl, started out in Denver, right? Nice big area here, not too many people, but lots of accidents, right? And then he moved to Pittsburgh, right there, right in this belt. You know, I don't think he arbitrarily moved or arbitrarily started his center in Denver. You know, I think he studied the map a little before he decided where he's going to put his. So, What does UNOS actually do? Well, it facilitates the organ distribution, transplant, and donor matching to make sure that there's consistency across the country. It maintains the national list of people who are waiting. It monitors every organ match to ensure that there's compliance with policies. We don't have people going off. It collects, validates reports on the transplant data to make sure that we actually have data on which to make judgments. It promotes organ availability, so a lot of the campaigns we've had over the last decade or so to increase awareness about the importance of organ donation, to increase the number of people signing up for on their license plate and other things are run by UNOS. Lots of secretaries of state and others do that, but UNOS has been very instrumental in this. It provides some assistance to patients and family, but the main thing it's supposed to do is have this sort of equitable donation across places. So UNOS, it says, the policies are designed to make the best use of the limited supply of organs and give all patients a fair chance at receiving the organ they need regardless of age, sex, ethnicity, religion, lifestyle, or financial social status. So that's their charge. And one question that's worth asking is, does it succeed? So do UNOS policies make the best use of limited supply of organs and give all patients a fair chance at receiving the organ they need? So most of you, a third of you say yes, and 2/3 of you say no. So here are some of the things that the UNOS criteria depend upon. Medical urgency, tissue match, blood type, waiting time, the size of the organ, right? You don't want to put a 42-year-old liver into a 1-year-old baby. Immune status, geographic distance. One of the things you may have noticed if you read the policies and could get through all that technical regulatory ease is the fact that they don't use the same criteria for all the organs. The criteria for livers is different than the criteria for allocating kidneys. So how does UNOS actually do it? The first thing they do is a screening for compatibility. And the compatibility is blood type, because you can't transplant different blood types. Height, weight, people are screened out, right? If you need to have a liver that fits, you need to have a kidney that fits. You can't put an adult kidney into a little baby, as I mentioned. So that's a first cut. And is it going to just physically, mechanically work? Then, in the case of livers, all right, and remember, I emphasize we have different criteria for different organs. We have 3 major criteria. One is medical urgency. So those with the most urgency go to the top. We have geographic proximity to the donor. Those who are in the local area get priority. Those who are in the regional UNOS region, and then they open it up to the national area. And then the donor's age, adult versus pediatric, not the recipient's age, the donor's age. So if we talk about this urgency, a lot focuses on the status 1A and 1B. Status 1A are adults or children with acute fulminant failure and a life expectancy of hours, a few days without a transplant. So these are people who, for whatever reason, sometimes we don't know, but one case that I saw when I was practicing, people, I think I mentioned, ate some mushrooms, completely knocked out their liver, and were both, it was a man and a woman who went out hunting for mushrooms, would die in a matter of hours if they didn't have a transplant. Another very common case is someone takes an overdose of Tylenol. What Tylenol does is to knock out your liver function, and that's another. Status 1B is restricted to children. They have chronic liver failure, that is, it's slowly declining, and they, layered on that, might have taken a bad turn, and they're getting, their liver function is rapidly deteriorating and life-threatening. Now, there are very few of these patients at any given moment, fewer than 10 nationwide. You either transplant them and they live, or you don't have an organ and they die. And so at any one time, the steady state is not going to be, even in a country of 300 million people, not that big a pool of people. So while these people get very high priority, top priority, because if you don't do anything, they will die, there aren't that many of them. What principles are at play in giving status 1A, 1B patients priority? Is it lottery? Is it prognosis? Is it save the most lives? Is it sickest first? Is it youngest first? Yeah, this is about sickest first. This is about, we've got really sick patients who are going to die in hours or maximum a few days. They need priority. Prognosis is not their prognosis with the illness. Their prognosis means prognosis with the transplant. Okay? After status 1A, 1B patients is the MELD score, which is the Model for End-Stage Liver Disease score. And it's a numerical score based upon just a handful of criteria that predict how sick patients are. Ranges from 6, you're really sick, or you're not really sick, to 4, 40, you're gravely ill, fulminant death. And it's used to allocate livers to those people 12 years and older. So each person receives a score about how urgently they need the liver over the next 3 months. And it's based upon these 3 criteria. So those of you in the health field won't probably be surprised by it. Bilirubin is a measure of how effectively the liver excretes bile, which is what goes into the gallbladder. And the liver processes certain proteins into and fats into bile. And if the bilirubin is high, the liver's not doing a good job, and it's backing up in the system, and you can measure it, and people, that's when people turn yellow, that's what you're seeing. Second, INR prothrombin time. These are a measure of how well the liver is synthesizing proteins. There are some clotting factors related to that, and if the liver is not doing its job in terms of synthesizing proteins, these clotting times are elevated, they're abnormally high. And the last thing is creatinine, which is not a measure of liver function, but a measure of kidney function. And the reason is that if you go into liver failure, you then subsequently, because you have a lot of these toxins running around not being purified, you knock your kidneys out. So the MELD is a combination of weighting of the bilirubin, the clotting factors, and kidney function. So what principle is at play in the assignment of a MELD score? Save the most lives, sickest first, prognosis, youngest first, or first come, first serve? Yes, we told you, sickest first, right? It said, what's the prognosis? These are good measures of prognosis, of how, not prognosis, of how sick or how likely a person is to die over 3 months. So the MELD is a way of numerically ranking people by who's the sickest at the moment and needs the liver. Now, why do we do proximity to the donor?
It affects the ischemic times and it affects the prognosis of the liver.
The value, right. So, if you take a liver out, you put it on ice, you transport it, the longer it's on ice before you transplant it, the more the liver itself is degrading. So if you got to fly 5 hours from Philadelphia to Los Angeles to get a liver and fly it back to Philadelphia, not a good thing, right? You want to have someone in the same hospital, so all you're doing is walking from one operating room to the next, and it's on ice for just a handful of minutes. So that's why people have local candidates with the organ procurement service area, or regional candidates who are in these larger, far from national regions. And you can see, you know, New York, you got a relatively small region. Even around Philadelphia, it's relatively well circumscribed. But if you get out west, and the distance from, you know, San Francisco to Santa Fe is hours of flight. And then, if you can't find someone in that area, in your region, you go national. This is the local OPO maps, local procurement area. And you can see here we are in Philadelphia, what's considered our local area. Or if you're in New York, you've got all these local areas, and New York State itself is a region. All right, and there's the regional maps. Okay, and then we mentioned before, is the donor 18 years or older? Is the donor younger than 18 to allocate to the right size? Is the donor younger than 10? So these are ways of getting you the right size. All right. If you look at this car accident, okay, here's our protocol. Do we have 1A followed by 1B in the same region? Right? You're looking for people who are sickest, going to die imminently in the same region. Then candidates within our local region, our local area, that have a MELD score of 15 or higher. And typically if you have a MELD score around 22, 23, you're going to get a liver soon. Then candidates in the same region that have a MELD score of 15 or higher. So first you have your local area, 15, MELD 15 or higher, and then you have your region, 15 or higher. And then candidates in the local OPO area that have a MELD score under 15, going to 14 and then 13 next. And then candidates in the same region, again, going down by MELD score. PELD, sorry, should clarify. PELD is the pediatric equivalent of the MELD score. MELD is for adults, P is for the pediatrics. Okay? And finally, number 6, you go nationwide. So you can see there's priority based upon MELD score within your local area, then within your region, then you go to people further down on the MELD score within your local area, within your region.